Today we are going to discuss the mitral valve regurgitation. So before we discuss mitral valve regurgitation, a little bit introduction about the mitral valve anatomy. Mitral valve actually is divided into two components. It's the valve proper and the subvalvular apparatus. The valve consists of a mitral annulus and the two leaflets, while the subvalvular apparatus consists of chordae tendineae and the papillary muscles. The valve leaflets are attached to the cardiac muscle through the papillary muscle and chordae tendineae, which are small tendons originating from the papillary muscles and attaching to the undersurface of the mitral leaflets. Now, it's a disorder which is seen in about 5 in 10,000 population, and when we see an echo, we may see in middle-aged and elderly, 20% of cases have some bit of MR, especially in the middle-aged and the elderly patient. So this is not clinically significant and sometimes does not produce any clinical symptoms and is diagnosed only on echocardiography. So these patients are not really requiring treatment, and depending upon the symptoms, they may require some monitoring, but generally it's not. You see, female sex, lower body mass index, advanced age, renal dysfunction, prior myocardial infarction, prior mitral stenosis, they increase the risk of having mitral regurgitation as well. Now, when we compare the developing and Western world as far as etiology is concerned, in the developing nations, the more causes of mitral valve regurgitation are because of myxomatous degeneration, while in developing countries, it is the rheumatic heart disease or the post-traumatic fever. Mitral regurgitation is more common. Now, it can be caused by many conditions, for example, mitral valve prolapse, rheumatic heart disease, infective endocarditis, mitral annular calcification, cardiomyopathies, ischemic heart disease. These are more common reasons for developing mitral regurgitation. The less common reasons are collagen vascular disorders, trauma, previous chest radiation, carcinoid syndrome, hypereosinophilic syndrome, and in patients who got mitral stenosis and they have undergone valvotomy, they can have mitral regurgitation as a consequence of percutaneous valvotomy. Almost 10% of the patient may have this valvotomy associated mitral regurgitation. Now, the mitral regurgitation is divided into two different types. One is primary defect in the mitral valves. The second one is the secondary abnormality. This is because of the abnormality in the LV itself, not in the valve apparatus. So primary abnormality may be seen in myxomatous degeneration, rheumatic heart disease, and ischemic heart disease, while this secondary type of mitral regurgitation is seen and patient has abnormally dilated LV cavity. Now, functional classification, the mitral valve regurgitation can be divided functionally into three different types: type 1, type 2, and type 3. In type 1, there is normal leaflet motion. The leaflets are moving normally. In type 2, there is excessive leaflet motion. For example, leaflet prolapse. And in type 3, there is restricted leaflet motion with either the restriction is in opening or the restriction is in closure of the valve. So they are called type 3A or sometimes type 3. This is the nomenclature used, that if they are not opening properly, this is type 3A defect. If they are not closing properly, this is type 3B defect. Now, what happens in type 1 defect? This type 1 defect is basically because of the annular dilatation. The annulus, which is holding the valves, the ring to which the valves are attached, starts stretching and it's becoming dilated. Or there is perforation in the valve leaflets. For example, if endocarditis or an abscess results in perforation in the leaflets. So the leaflets have a normal excursion, but the patient has regurgitation, because if the ring dilates, the leaflets, they cannot come close to each other because they are separated, but they are moving normally. Since they are separated, the patient starts having mitral regurgitation. Similarly, if there is a hole in leaflet, the regurgitation starts, but the valves have a normal movement. And then patients present with myxomatous degeneration, in which there is increased leaflet movement. The reason is the chordae tendineae are thinned out and they are stretchable. So this is seen in mitral valve prolapse. So when there is systole, the pressure rises in the left ventricle, the valve is pushed back, and since the chordae tendineae and the papillary muscles are weak, this valve overshoots into the left atrium. So this is the myxomatous degeneration, and the valve movement is increased. So this is seen in myxomatous degeneration or prolapsing mitral valve. And then we've got defect, third type of defect, in which there is restriction in the leaflet movement. That is seen in rheumatic heart disease, and sometimes it's also seen in ischemic heart disease. So what happens, the chordae tendineae are thickened, they are foreshortened, and they are the valve leaflets are sometimes tethered to the surrounding structure, so they do not move appropriately. So there is posterior dilatation of the mitral annulus as well. And similarly, patients who got ischemic dysfunction of the papillary muscles, they cannot hold down the valve normally. And when there is infarction of the papillary muscle, there is fibrosis, and the muscle and the chordae tendineae, they are shortened. So they do not stretch properly, and the valve leaflets cannot close. So this can result in diminished movement of the leaflets. So we can have mitral regurgitation with normal leaflet movement, with increased leaflet movement, and an MR with decreased leaflet movement. Now the secondary MR is functional. It is because of the valve apparatus is normal. There is dilatation of the left ventricle, which results in the stretching of the mitral annulus and displacement of the papillary muscle. This is seen usually in the dilation of the left ventricle, which is usually caused by cardiomyopathy, sometimes a chronic aortic regurgitation, and in some patients who've got diffuse type of ischemic heart disease, that all vessels are involved, and the patient has global hypokinesia and the heart starts dilating. In those patients, we have this secondary type of mitral regurgitation. Now what happens in mitral regurgitation? We see mitral regurgitation can be acute and it can be chronic. The chronic one can be a compensated and a decompensated state. So what happens in mitral regurgitation? There is malfunction of the mitral valve apparatus. There is mitral regurgitation, and there is reverse of flow of blood from the left ventricle into the left atrium. Normally the blood moves out of the left ventricle into the aorta. But when there is mitral regurgitation, the blood moves back from the left ventricle into the left atrium. Some of the blood also moves forward out of the aortic valve into the aorta. So the blood is moving in both directions. Now what happens when there is acute mitral regurgitation? For example, patient has inferior valve myocardial infarction or posterior valve myocardial infarction with the infarction of the papillary muscles as well. So papillary muscles sometimes may break off and the valve leaflet becomes flail. So, or sometimes it happens in infective endocarditis. So patient has an acute or sudden volume overload in left atrium and left ventricle, because the blood is moving back into the left atrium, and the same amount of blood which is moving into the left atrium is combined with the blood which is coming from the pulmonary circuit. So in left atrium we have got two sources of blood, the blood which is regurgitating from the left ventricle and the blood which is coming out of the pulmonary circuit into the left atrium. So left atrium has a high volume. This high volume goes into the left ventricle. So the left ventricle also has high volume. So the stroke work for the left ventricle is increased. So when there is acute MR, there is a sudden rise in the pressure in the left ventricles. There is increased left ventricular filling pressure combined with transfer of blood from the LV to LA during systole. This pressure is now transmitted back from the left atrium into the pulmonary circuit. That results in sudden onset of pulmonary edema. The patient presents with sudden onset of pulmonary edema, especially patients who got myocardial infarction. On third or fourth day, if they develop sudden onset of shortness of breath, either there is a rupture of the papillary muscles or there is rupture of the interventricular septum. So the patient presents with a sudden onset of pulmonary edema. The patient is got an MI, patient is being treated, and for first 1 or 2 days the patient is asymptomatic, and then suddenly the patient develops features of pulmonary edema. So that means either the acute MR has started or there is perforation of the interventricular septum. So the patient presents with, in a dramatic way. This patient is in severe dyspnea. Sometimes the patient is in shock as well. But what happens in chronic mitral regurgitation. The situation is slightly different. There is gradual increase in the volume overload, so there is time for the heart to accommodate. So there is increase in left ventricular end diastolic pressure and left atrial pressure. But since this is a slow process, the left ventricle accommodates and starts enlarging. There is compensatory dilatation to accommodate the large volume so that the intraventricular pressure does not rise. So the volume is high, the left ventricle starts dilating, so the pressure is less and less. So this is how the cardiac output is maintained. The high preload with large stroke volume. Since according to the Frank-Starling law, if we stretch the muscle, it contracts more vigorously. In these patients, since there is a large end diastolic volume, so the ventricular cavity is dilated, that results in forceful contraction. So the stroke volume is increased, but this stroke volume goes in both ways. It goes into the atrium and it goes into the aorta. So this increased stroke volume maintains the peripheral perfusion and the cardiac output. Alveolar dilatation in chronic MR leads to worsening of the MR. So as the heart starts dilating, the MR further worsens. So a vicious cycle starts. There is decreasing ejection fraction because with the time the heart dilates, the contractile dysfunction starts coming into picture. The heart's contraction over a long period of time, when the heart has to maintain the cardiac output with increasing dilatation and increasing heart rate, the contractile dysfunction starts coming in. Probably the myocardium starts getting fibrosed. There is decreased ejection fraction leading to high left ventricular end diastolic volume. There is high left ventricular end diastolic pressure and left atrial pressure. So you see, with the increasing volume, as the disease goes on, the intraventricular and intra-atrial pressure starts rising. These pressures are now being transmitted back into the pulmonary circuit, resulting in pulmonary hypertension and then the right heart failure as well. So there is reduced stroke volume, reduced cardiac output in the forward direction, and this backward pressure which is transmitted into the pulmonary circuit results in pulmonary hypertension. So patients start having not only forward failure, the patient also starts having failure in the right heart as well. Now, what are the symptoms of mitral regurgitation? You see, chronic compensated mitral regurgitation may be asymptomatic with patient going on without symptoms for many years, maybe 10 years or maybe even 15 years. The symptoms are because of decompensated congestive heart failure and low cardiac output state, and the patient may have palpitations. The palpitations develop if the patient has atrial fibrillation. When the atrium starts dilating, atrial fibrillation may set in. So patient may have palpitations because of atrial fibrillation. Sometimes the patient present with the complications of atrial fibrillation. That is, patient may have embolic phenomena into the peripheral circulation. There may be stroke, there may be peripheral vascular disease, there may even be an MI. Patient may have gut ischemia, there may be kidney ischemia. So the patient may come with the complication of atrial fibrillations. Then patient has a low cardiac output state. As the heart starts failing after a long latent period, there is decreased exercise tolerance. And since there is decompensated heart failure, patient complains of shortness of breath, and there is orthopnea and sometimes paroxysmal nocturnal dyspnea as well. Now, acute MRI, as I mentioned, presents differently. It presents with a sudden onset of pulmonary edema, and later on the patient develops the complaints like dyspnea, fatigue and orthopnea. But in the beginning it's a dramatic event and the patient comes with a sudden onset of pulmonary edema. The patient is very short of breath, and sometimes the patient, they present or they are already admitted and they develop a complication of acute MR and they are in a state of shock. Physical examination, the pulse usually is good volume, and until patient develops atrial fibrillation, it is usually a good volume regular pulse. But if the patient develops atrial fibrillation, this is irregular pulse. When you examine the precordium, the apex beat is displaced and the apex is usually hyperdynamic. This may be a heaving apex beat. The first heart sound is soft. It may sometimes may not be audible. Second heart sound may be normal or it may be loud. That is, the pulmonary component is loud if the patient has developed pulmonary hypertension. And if the patient has volume overload, you may hear a third heart sound as well. Now the murmur. The murmur is located at the apex. It may radiate to the axilla or back toward the subscapular region. It may also radiate to other portions. For example, it may radiate upwards. This is usually a high-pitched blowing murmur. It's a pan-systolic murmur. There is no relation between the severity of the murmur and the intensity of mitral regurgitation. So the loudness of the murmur does not correlate with the severity of the mitral valve regurgitation. Now there are some variations. For example, in acute mitral regurgitation, the murmur is only early systolic, and sometimes in mitral valve prolapse, it is late systolic, and you may have mid-systolic clicks with mitral valve prolapse. So the patient may have pan-systolic murmur in chronic MR. In acute MR, it may be early systolic, and in mitral valve prolapse, it may be mid to late systolic murmur. There may be mid-systolic click, and sometimes more than one clicks may be present. The differential diagnosis includes aortic regurgitation, it's a good volume pulse, dynamic apex beat. Then you have aortic stenosis as one of the differential, because sometimes the murmur of aortic stenosis radiates towards the apex. Then it's one of the complications of acute myocardial infarction. It should be recognized, and it should be in fact anticipated that patient might not develop this sort of complication, especially the posterior or inferior wall MI. With the anterior wall MI, it's actually the septal perforation usually, not the MR. Then mitral stenosis, pulmonary regurgitation, pulmonary stenosis, and VSD are the other differential diagnosis for this condition. Then a different test we can do in addition to the routine testing like complete blood count to see the hemoglobin, the presence of infection, may be suggested by a high TLC or a high ESR. We should do the other baseline tests, for example, the renal function test, the liver function test, the electrolytes, and the blood sugar. The ECG in these patients may show inferior wall infarction or posterior wall infarction. There may be enlargement of the left atrium, and there may be LV hypertrophy seen as STT changes in the lateral chest leads. The chest X-ray shows enlargement of the left ventricle. In chronic mitral regurgitation, there may be pulmonary edema and congestion in heart failure, and pulmonary edema may be in acute MR. The left atrial enlargement seen in anteroposterior view, and there is straightening of the left cardiac border because of the enlargement of the left atrial appendage. So you may see on X-ray enlarged LV, pulmonary congestion, enlarged LA, and the left border of the heart may be straightened. Then echocardiography is an investigation of choice for patients who got MR. We see multiple signs on echocardiography for mitral regurgitation. For example, we may see a flail leaflet. There may be a ruptured papillary muscle. There may be large coaptation defect. That is, we may see a flail leaflet means the leaflet is moving to and fro. It's not really coapting. Ruptured muscle may be visible, and the large coaptation defect, that is, the valves do not touch each other. So this may be seen. You may see on color flow there is a large central jet or eccentric jet which is reaching the posterior wall of the left atrium. There may be dense triangular continuous wave signal of regurgitant jet that may be seen, and large flow convergence zone may be seen in the left atrium. So all these may be seen on echocardiography. This is the investigation of choice. Now, who are the patients who require serial echo? Because patients who are asymptomatic, the disease may not be severe, but since this disease is progressive, we have to see the progression of the disease. This can be done by echo. Sometimes it can also be done by the brain type of natriuretic peptides as pro-BNP. But practically, serial echo is the investigation of choice for assessing the progress of the mitral regurgitation. So we have two types of echoes, transthoracic echo and transesophageal echo. Transthoracic echo should be done yearly, moderate mitral regurgitation. While patients who've got asymptomatic severe mitral regurgitation, the clinical evaluation and the echo should be done every 6 to 12 months, and if the patient develops symptoms. So if the patient is asymptomatic but the MR is severe, it should be done every 6 months to 12 months, and the patient becomes symptomatic, then it should be done immediately. Then transesophageal echocardiography can be done if the etiology is not clear. We can go for T. to determine the feasibility of mitral valve repair. And then evaluation of mitral valve and associated structure when transthoracic echo is not clear. And then when we do the cardiac catheterization, that is left ventriculography and hemodynamic measurements, when do we do this? This is not usually done in only a few cases. For example, if non-invasive tests are inconclusive or conflicting, that is, we cannot determine the severity of MR, the LV dysfunction, or is there a need of surgery or not. So in those cases, we can go for cardiac catheterization. Similarly, if the pulmonary artery pressure is out of proportion to the severity of MR, if echo tells us the MR is not severe, but the pulmonary artery pressure is very high, in that case we need to do cardiac catheterization to see, is it really the mitral regurgitation causing pulmonary hypertension, or there is some additional factor. For example, there may be associated idiopathic pulmonary hypertension. And in patients who are at risk for coronary artery disease, or those who are suspected of having mitral regurgitation because of the ischemic heart disease, in these patients we can go for this invasive studies. Now we stage the mitral regurgitation into stage A, B, C and D depending upon the severity of the valve. For example, stage A patients are at risk of mitral regurgitation. For example, patients have mitral valve prolapse, but still the valves are not prolapsing and the regurgitation is not there, but these patients are prone to develop. Patients who've got dilated heart, they tend to develop MR. Then stage B, patients have asymptomatic MR which is progressive in nature. We serial echo show that this is increasing. Stage C is patients who are asymptomatic with severe mitral regurgitation. And then stage D is patients who are symptomatic with severe mitral regurgitation. Now what is the treatment option? Keep in mind one thing, that in the left upper corner, intra-aortic balloon pump is required in patients who got acute mitral regurgitation as a consequence of, say, acute regurgitation of the or acute rupture of the chordate tendon, because the patients are in shock, hemodynamically compromised. In those patients, intra-aortic balloon counterpulsation may be required. And then you see treatment for chronic endocarditis. For all valvular disease, no drug is able to correct the valvular defect. With the drugs, we can handle the hemodynamics problems which are a result of valve function failure, either stenosis or regurgitation. So medical management is the afterload reduction with vasodilators like ACE inhibitors or ARB. Since when the ventricle contracts, the blood is moving in both directions, into the atrium and into the aorta. If we decrease the afterload, it will be easy for blood to move out of the left ventricle into the blood vessels, into the peripheral vessels, if peripheral vascular resistance is decreased. So we go for afterload reduction, and diuretics if the patient develops the symptoms of LV dysfunction, that is heart failure. Then we go for rate control and anticoagulation in patients who've got atrial fibrillation, or anticoagulation in patients who have been replaced with valves. Rate control can be achieved with beta blockers, with calcium channel blockers, with the patients who are in sinus rhythm with ivabradine. Patients who are in atrial fibrillation, we can use digoxin or we can use amiodarone to control the rate. Then patients who develop mitral regurgitation, they should be given infective endocarditis prophylaxis if they are undergoing a procedure in which there is a possibility that there may be bacteremia, for example, dental extractions or endoscopic examination of the urinary tract, of the GI tract. So we go for prophylaxis in patients who've got prosthetic heart valve, previous episodes of infective endocarditis, patients who got cyanotic congenital heart disease or shunt reversal, for example, Eisenmenger syndrome, and valvulopathy in a patient who had a cardiac transplant. So in these patients, we go for endocarditis prophylaxis. And the treatment is surgery. It is either valve replacement, we put in a new valve, or repair of a plate leaflet perforation. A perforated leaflet can be stitched. Sometimes the edges of the valves, they can also be stitched to decrease the mitral regurgitation. And then annuloplasty, if the ring has dilated, the rings can be shortened so that the valves can coapt. Now the complications of the mitral regurgitation are pulmonary edema, congestive heart failure, irreversible left ventricular systolic dysfunction, and thromboembolism resulting from atrial fibrillation. So these are different complications of MR. Then we got surgical complications. Surgical complications include, at the time of surgery, there may be infection, there may be bleeding, patient may have stroke, patient may have MI, and then we put on prosthetic valves. The prosthetic valves have some complications. For example, there may be prosthetic valve infection. And then the bioprosthetic valves, they may show degeneration and calcification, and they may require replacement. If they are in sinus rhythm, anticoagulation is not required, but if atrial fibrillation develops, anticoagulation is required. Mechanical valve, anticoagulation is required. If anticoagulation is not appropriate, there may be mechanical valve dysfunction because of thrombosis, and thrombosis may be associated either with or without peripheral embolism. And there may be hemolysis because the discs which strike to each other in metallic mitral valve, they may result in hemolysis. So these may be complications of the surgery. So this was all about mitral valve regurgitation. For now, we close our lecture, and we will meet another lecture next time. Till then, goodbye.